Welcome back. Our next speaker is Dr. Cesar Cipriano de Leon Dimayuga, who, like Dr. Dunca, is also a fellow of the Philippine Orthopedic Association. He will discuss non-surgical management of osteoarthritis of the knee. Dr. Dimayuga obtained his medical degree also from the University of the Philippines College of Medicine in their intermed program. He had his residency training in orthopedics at the University of the Philippines Philippine General Hospital and fellowship training in orthopedic oncology and sports medicine and arthroscopy in University Hospitals of Cleveland, Case Western Reserve University, University Hospitals of Cleveland, Cleveland, Ohio. He also has a master's in business administration in health, where he obtained it in Ateneo de Manila University. His hospital affiliations are the following: the Medical City in Ortigas Avenue and Capital Medical Center in Quezon City. And of course, the Philippine General Hospital. May I present to you Dr. Dimayuga.
Good afternoon, everyone. So we'll be discussing about specifically the osteoarthritis of the knee, the non-surgical approach. So let's start off with a 64-year-old female who came to my clinic and with a complaint of left knee pain for about 2 years. It's usually felt when she is getting up from a prolonged sitting position and when she goes down the stairs. On physical examination, there's note of genu-valgum, tenderness on the lateral joint line. There was mild crepitation and no effusion. X-rays showed a narrowing of the lateral joint space. And therefore, how do we now approach this patient? So we do know that given the physical examination and the history and the X-rays that the patient has osteoarthritis of the knee. So therefore, we have to treat the patient in terms of what the symptoms are, which is mainly pain, and also address the osteoarthritis. So the next slide will show you what I basically follow in my clinic when I see these patients with osteoarthritis of the knee. And I tell them, first of all, that there's no cure for arthritis of the osteoarthritis of the knee. There's nothing, no medicine, no surgery, no physical exam that will make their knees go back to like when they were 20 years old. However, there are things that we can do to minimize the pain and also slow down the process by which the arthritis will progress. Okay, so we talk about number one, what activities a patient should avoid or minimize. Then exercises that would strengthen mainly the quads and also that of the hip abductors. The use of assisted devices, weight management. We talk about the medical management for these cases, whether it's going to be topical, oral, or injectables. And if needed, then we will talk about surgical options. So let's start with what activities a patient should avoid. I usually tell them to avoid frequently going up and down stairs, especially going down. And the reason why it's more painful going down is that when you go down, the leg that is left behind is actually bent more than this knee, which is used to going up. So because the knee, when it's more bent, will have a vector of force pushing the kneecap backwards. So patients with arthritis of the knee is usually more painful for them going down. Of course, they try to avoid kneeling, squatting, sitting in a low chair, tucking your feet underneath the chair when seated, again, to avoid this particular situation. Going up and down inclines or declines, again, it's worse going downhill than it is going uphill. And when they are into any exercise program, to rather focus on what we'll talk about as closed kinetic chain exercises rather than open kinetic chain exercises, and to avoid high impact activities. Here we can see that in certain exercises, like closed and open kinetic chain. By the way, what is a open kinetic chain exercise? An open kinetic chain exercise is that when you Extend your knee against the resistance and your feet are free. It's not planted on any surface. Whereas a closed kinetic chain exercise is that your feet are planted as you extend your knee. So here there was a study where they compared the amount of reaction force on the patellofemoral joint. It is lower in a closed kinetic chain exercise such as leg press or vertical squat when it is in the lower degrees, meaning from 0 to 46, or this one less than 85 degrees. Whereas in the leg extension exercise, which is an open kinetic chain, it is lower at the higher degrees, 50 to 90 or greater than 57 degrees. So this is to demonstrate what I do not lock my knee when I extend it fully. Neither do I bend my knee more than 40 degrees. That way, I stay within the lower range of the motion for the knee when I do this closed kinetic chain. Therefore, there's less stresses to my kneecap while I'm strengthening my thigh muscles. Here in the squats, sorry, oh, doesn't funny, voila. Go ahead. I have to get the pointer. One moment, please. Oh, hello. Okay, when we do the squats, it's the same thing. A common mistake is that you see people doing a half squat, and sure, it may look good, but they're at the same time they're destroying their knees. So, I personally do not do this exercise again because of problems I have with my kneecap. So this is just to demonstrate how it is done. Then there's always the question of whether do you advise patients to jog or to walk or should they bike? There are a lot of studies showing that there is the joint line if you're actually jogging versus walking. But the issue here may be perhaps what kind of landing do you have when you jog? You should land on the forefoot, yes, and not land on the heel. Okay, that way you avoid stresses going to your heel, knee joint, hips, and back. Whereas when you do walking, especially brisk walking, and you do a heel strike, then the force is actually transmitted from the heel to the knee, to the hip, and to the back, and may actually cause problems. Biking is actually okay because there's less stresses going through the knee, but make sure that when you down pedal, that your knees are about 30 degrees bent. So the next chart simply shows you the amount of forces that actually are transmitted to the patellofemoral joint by the different activities. Walking and biking is the lowest. It does go higher with jogging and squatting. But again, if you do it properly with the right surfaces, and of course you have to look at your level of health and in terms of how your knees are, whether you can do the exercises. So not all exercises are for everyone. So what exercises do I actually ask my patient to do? I focus on strengthening for the quads, mainly what you call the vastus medialis obliquus. So this muscle over here is what mainly controls the knee. So we do two exercises. One is called quad setting, and the other one is straight leg raising. Okay, so for the quad setting exercise, basically just ask a patient to squeeze down. There you go. If you squeeze down against a bed or against a mat, and you hold that for about 5 seconds, then I usually tell them to do about 20 reps and do 3 sets of that. If the patient does not understand exactly what you want them to do, you can put your hand underneath the patient's knee and tell them to try to squeeze your hand against the bed, and they basically get the idea. The other one is the straight leg raising. For the right leg, again, they tighten the right knee, lift the heel about 12 inches off the bed, and they point to the 2 o'clock position. For the left, knee, it's with the foot pointing at the 10 o'clock position. When you do this, it is the VMO that is actually emphasized rather than with the toes pointing up. You must also understand that the knee doesn't stand alone. It actually belongs to a kinetic chain of joints affecting the extremity, meaning to say you have your feet, you have your knees, you have your hips, including your back. And they've seen that patients who have weak hip abductors, they have a tendency to put their hip in adduction and internal rotation. And when that happens, you put additional stresses to the knee. So one of the exercises that I also add for my patients is the side lying hip abduction exercise, by which we try to um, strengthen their hip abductors. If you're also prone to foot pronation, then you may have to put some orthotic devices in your footwear to avoid foot pronation, which puts, again, undue stresses to the knee joint. Using assisted devices. You can see a patient sometimes coming to your clinic, they're already using a cane. And if they have a painful right knee, most of the time you see them using the right hand holding the cane. And then you have to teach them that the correct way of holding the cane, it should be on the opposite side of the side which is painful. And then sometimes you have to look also at the height of the cane, that when they hold the cane, the elbow should be about 30 degrees bent. So one way of doing that is when they're standing, the upper portion of the cane should be at the level of the wrist of the patient. And you need your elbow to be slightly bent because it's basically your triceps, which helps support the other leg, and you need to extend the elbow to activate the triceps. Dr. Dunka also mentioned about bracing to unload the joint. So in this case, where we have unloaded braces, this is also available in our country. Where a patient with a alignment problem, like in this case a genovarum, and if they applied the unloaded brace, the medial joint line actually opens up. So this is again one of the options you have for patients who would still not like to undergo surgery. Weight management is important because, again, the added load to the knees will increase the wear and tear of the joint. So, again, we talk about proper food intake, so high fiber carbs, lean meats, HDL rich fat. They should eat more often rather than doing starvation type of diets. And they should take in lots of fluids because when you take in lots of fluids, the metabolism of your body will become more efficient, therefore you burn more fat. Then you have to pick the appropriate cardio and strengthening exercises for your patients given their level of conditioning. Going to the medical management, okay, I basically would like to refer to a guideline issued by the European Society for Clinical and Economic Aspects of Osteoporosis, Osteoarthritis, and Musculoskeletal Diseases, or the ISEO treatment algorithm for knee osteoarthritis. Unlike other guidelines where they would give you the strength of evidence whether one intervention is actually working or not, here they attempt to give a area of prioritization of which intervention to use first before you proceed to the next. So this is just a shot of the how the guidelines go, and we'll go to it in a little bit more detail. So the first part we talked about the core set. The core set is something which we would include the exercises, the weight loss, and definitely education. You have to teach your patient about what they have and what they can do about it. Then if the patient is symptomatic, then you have to start some treatment, medications. Paracetamol can be given, or you can also give something called your Cisadoas. In addition to this, you can also refer to PT for bracing if needed, or insoles, especially for those patients who are prone to, who are pronators. And if this still doesn't work, you can add a topical NSAID. We also talked about the walking aids, such as the cane. So all of these are part of step one. So why did they put paracetamol in parentheses here? We do know that paracetamol is not safe as it is actually thought to be. We were taught before, paracetamol is the safest drug to take. When in reality, they've been seeing now that a number of studies where it actually can harm um, um, our multiple organs. So the more common one would be the liver. So they actually put the upper limit to paracetamol to about 3 grams per day. Here they've also seen that um, because they place paracetamol in most guidelines as the first drug of choice, the essay was actually questioning in terms of how effective it was. So later on, we'll talk about the ES, okay, which is basically how effective a particular drug is. And if it is less than 20, then the efficacy is not as good. And they've seen that because of that, they will actually give an alternative approach where they will start with a Cisadoa and add paracetamol in case there's still additional pain. So we'll talk about ES, which is the effect size. What exactly is it? It's a way of quantifying the size difference between two groups. So in this case, between this group and that group, this group and that group. So you look at the mean of the experimental group minus the mean of the control group over the standard deviation. So what is its significance? If it's zero point 0.2, that means it is small. Like if, for example, the height difference between a 15-year-old and a 16-year-old would be very small. If it's zero point 0.5, then the effect is medium. Like let's say the height difference between a 14-year-old and an 18-year-old. Or if it's zero point 0.8, then it's large and grossly perceptible, such as the height difference between a 12-year-old and an 18-year-old. Therefore, a drug to really be effective in using this effect size, it should be zero point 0.2 or greater to actually have any effect. So this study done by Roberts in 2016 looked at the safety issue of paracetamol. So it's a systematic literature review, and they actually saw that there was increased mortality, cardiovascular events, gastrointestinal events, and renal adverse events in people who are taking paracetamol for long periods of time compared to the general population. And the effect size of paracetamol in pain in osteoarthritis of the knee is only 0.14. That means it's less than 0.2. Okay, so with that, they are looking at other options, not just paracetamol. So they're looking at using Cisadoas. So this one is looking at glucosamine sulfate, which is a prescription type. And we've seen that the effect size was 0.27 on pain and 0.33 on function. That means there is um, a little less than moderate effect. And that in terms of joint space narrowing in a 3-year study, there was also an effect size of 0.32. While that of many studies which were done on non-prescription type of glucosamine sulfate and studies done on glucosamine hydrochloride, there was actually no effect. So people ask, how exactly does glucosamine sulfate work? Does it, if you take it orally, how does it get into the joint? So how will that work? Well, basically, it works by the mechanism of interleukin-1 suppression. Interleukin-1 actually leads to increase of your inflammatory factors in the joint. And when you give glucosamine sulfate, it will break the cascade of the interleukin-1. Therefore, there's less inflammatory factors in the joint and therefore a slowing down in the destruction of the knee joint. And they've seen that for that to have an effect, you have at least around a 10 micromole concentration of the glucosamine in the blood for that to actually work. So they've seen that for the prescription type of glucosamine sulfate, they get levels of about 8.9 plus or minus 0.7, whereas taking the same dose of glucosamine hydrochloride, they were only getting 2.7 plus or minus zero point 0.9. So that clearly shows that glucosamine hydrochloride does not work in terms of that mechanism, whereas the prescription type of glucosamine sulfate does. There's also a prescription quality type of chondroitin sulfate which may have some benefit. So unfortunately, this is not available in our country, where the effect size on pain is small to moderate. Other cisadoras, such as the avocado soybean thing which is available in our country has limited evidence. The other cisadoras, like collagen, for now has no strong evidence showing its effect. But those who would like to read on glucosamine hydrolysate, which is basically there's a brand common in our country. There are studies on the web that they cite two local ones and one international study. The international study is still saying that there's not enough evidence for it. The local studies show an effect in decreasing pain. So, if it's still painful despite your Cisadowas and paracetamol, then you can add your topical NSAIDs. Okay, there's actually a moderate effect size using these, and there was no significant difference with oral NSAIDs compared to the topical NSAIDs. That's interesting. But obviously, the topical NSAIDs had a better GI safety profile. Um, Again, there's a lot of heterogeneity because of different kinds of topical NSAIDs. So you will have to look at each one and try to see how each would work compared to the other. The capsaicin again is in parentheses because there's actually poor evidence of efficacy in this, and there is a lot of skin reaction or adverse reactions to topical capsaicin. Now, you've gone through step one, it's still painful. What do you do now? Then we can go to step two, where we now add on our NSAIDs. Now, if the patient has normal GI risk, then a non-selective NSAID with PPI, without PPI will actually work, or you may give your COX-2. If there's increased GI risk, then you give your COX-2 with a PPI, and you avoid the non-selective NSAIDs. If there's increased cardiovascular risk, the one with the best safety profile would be naproxen. And for patients who are taking low-dose aspirin, please do not give diclofenac or ibuprofen, high-dose diclofenac, ibuprofen, because they actually attenuate or they lower the effect of your low-dose aspirin. And there's now been noted increased cardiovascular events on patients taking NSAIDs, these NSAIDs with low-dose aspirin. Okay? And of course, for renal risk, then you avoid NSAIDs, period. If they're still symptomatic, then you may either give your intraarticular steroids or your hyaluronic acid. So, NSAIDs, we don't usually give them continuously. We usually give them for long cycles or intermittently because of the side effects. And the effect size is small to moderate at 0.29 in terms of pain, which is basically almost similar to that of a Cisadoa. For the longer cycles, well, they've seen that if you actually combine a Cisadoa with the NSAID, there is a decrease in the amount of NSAIDs that are used. So we never use NSAIDs chronically, but we do give it in longer cycles. Again, check your safety concerns and give only when appropriate. For the hyaluronic acid injections, the effect size is zero point 0.3 to zero point 0.4, so not bad. But again, there's high heterogeneity because there are again different kinds of hyaluronic acid. Okay, and they do last, however, in terms of their effect, longer compared to a steroid injection. There is, however, the side effect that you might have swelling after a hyaluronic acid injection for certain types. So we do know that for a hyaluronic acid uh, injection to work, it should be more towards a high molecular weight type rather than the low molecular weight, which is a kind of synovial fluid that you have in a osteoarthritic knee, similar to what Dr. Dunca was showing you when he aspirated the knees. Okay, usually you get a clear synovial fluid, but it is a poor quality type. The hyaluronic acids have at least three generations. You have the first, the second, and the third. What's available in the market here are more commonly the second and third generation. The reaction that we do get in terms of the effusion is more commonly seen in the second generation type because of the formaldehyde that's actually seen there, what is used in their cross-linking. So why do we use it? It can supplement the damaged and degraded hyaluronic acid. Okay, it stimulates de novo production of hyaluronic acid by the synovial cells. This localized treatment and may limit the risk, of course, of systemic treatment and potential for Prolonged pain relief, anything from 6 months to 11 months average. And then, of course, there's the steroid injections. In my practice, if the pain is moderate to severe, I start off with a steroid shot because a hyaluronic acid injection, the patient will get the relief 1 to 3 months after you give the injection. And after spending a significant amount of money for the hyaluronic acid injections and the patient does not feel immediate relief, you might lose that patient. So make them happy. You give them first with a steroid shot if it's not contraindicated. The effect is purely local, will not have significant systemic effects, and the patients will get immediate relief. I would advise them, especially if I would think that they may be needing longer pain relief and I want to minimize oral pain medications, that I may give a hyaluronic acid injection a month after the steroid shot. Again, step three now is they may give short-term weak opioids. This would be basically in our setting tramadol, and they may also give a antidepressant called duloxetine. Okay, so um, here the weak opioids, they would put it as step three. In my practice, actually, if I already see that the patient may be needing long-term pain relief, I might even include this in step one, as long as the patient does not exhibit the usual side effects of opioids or weak opioids, which are nausea, dizziness, drowsiness. And one way to actually minimize that kind of a side effect is that you start slow. You give it, let's say, one tablet once a day for the first 2 to 3 days, then give it one tablet 2 times a day for another 2 to 3 days, and then before you give it at 3 times, 3 tablets a day. That way, you may get the good result you want without so much of the side effects. Then again, the antidepressants again a choice. I personally do not have experience with this with the duloxetine, but this is one of the options in step three. And obviously, if all of these fail, then you have surgical procedures. For patients 50 and above, or say for 60 and above, then you can offer them now total joint replacements. For younger patients, where you still want to avoid this, then there are other things you may want to do, arthroscopic procedures, maybe of some temporizing benefit for these patients. Okay. Um, and if your patients are poor risk and surgery is contraindicated, then definitely there is a role to refer your patients to your friendly pain specialists so that they can be given your stronger opioids. So, to summarize, basically, every patient is different. You will have to look at the different armamentarium available to you in terms of dealing with your patient. What I discussed was basically a guideline to see which and the steps on which drug or intervention can be given at any one point in time. So um, the core, the basic stuff that's done for everyone, but the exact drugs, whether it be the topical, the orals, the injectables, and eventually, if surgery is needed, you will have to assess your patient and give them the best advice. Thank you very much for your attention.
Thank you, Dr. Dimayuga. That was a very nice lecture. We have a question here from one of our viewers. Do you do your exercise treatment or prescription yourself, or do you just simply refer your patients to your physiatrist?
For my patients, the very basic one, basically, I teach them three basic exercises: quad setting, straight leg raising, and lying hip abduction. These alone are very easy to do, and your patients can do it. And you know, you're very capable actually of instructing your patients how to do them properly. And you don't have to refer to the physiatrist for that. Um, so I don't normally do a referral to the rehab immediately. There are certain cases where the patients may have a harder time following instructions or may have other medical problems where again they may need more conditioning. There may be other situations where like realignment of certain orthotic devices may be needed, then I do refer to the physiatrist. So those that you can basically handle on your own, then go ahead. But if you do need the rehab, then by all means, please refer them to your rehab friends.
Thank you. How about oral steroids? Is there a role for oral steroids in knee OA?
Well,
Or
there are quite a number of side effects of systemic steroids, which um, I well, personally I do not. I do not give oral steroids because of those side effects. Because I do have other options in terms of systemic therapy, which will not have those side effects. Well, as you do know, local steroids, that I do a lot. Okay, so I would combine the local steroids and I have to give something else systemic, then I would do so without risking the side effects of oral steroids.
so, how often can you give your intraarticular steroid?
The advice is usually we do not give them at intervals of less than 3 months. The thing about intraarticular steroids, they do work beautifully in terms of symptomatic relief. However, they also will destroy the cartilage if you give it too often and can actually worsen the osteoarthritis. So if you are now having to give intraarticular steroids at intervals of less than 3 months, it's always painful, then I would really try to push a patient for a more long-lasting relief, and that will probably be a knee replacement.
How about non-steroidal anti-inflammatory? How long do you prescribe them per consult for a given patient?
Again, it depends on the type of NSAIDs. Again, the safety profile of certain NSAIDs, based on the studies, can go as long as 3 weeks. But the rule of thumb about NSAIDs would be give them at the shortest possible time where you can get the relief that you want. Okay, but you do not exceed a certain level. I mean, personally, I give it at most 10 days, as long as the patient does not have any contraindication to the NSAID and they tolerate it well. Very seldom will I go beyond that at any period of time. But there are certain cases where, yes, I've given 15 days, uh, but again, not that often. Most of the time, I do try to be aggressive in terms of my management. There is such a thing called multimodal treatment, and multimodal treatment is do not rely on any one specific pain relief modality. It can mean you're giving drugs with non-pharmacologic um, treatment at the same time, or you're giving pharmacologic treatment of drugs having different mechanisms of action along the pain pathway. By doing that, you now are able to get pain relief faster with lesser side effects per drug. Okay, so that way, do not rely on just NSAID and hope everything works. If it's not working within the first few days, then do add something else.
Okay, you mentioned about glucosamine. You kept on mentioning sulfate, but there are some in the market which has hydrochloride.
Yes.
Is it as effective as your sulfate?
So we show the slides where glucosamine hydrochloride given also at 1,500 milligrams, which is the same dose that you'll be giving your glucosamine sulfate, the prescription type, not again the supplement, that the blood levels go to only about a third to 40% that of the prescription type of glucosamine sulfate, and you do need a certain level of glucosamine in your blood for it to inhibit IL-1, and there's no way that that will work. So I do tell my patients, since your body will select to metabolize the glucosamine hydrochloride and it will not work, just throw it in the trash can. That's where it belongs. Sorry for those who are taking glucosamine
Yeah,
hydrochloride.
there's more in the market of hydrochloride.
Yes, definitely. Yeah. Okay.
Another,
Now, yeah, for the glucosamine sulfate supplements, again, the studies are not yet so much out on it, but again, it is not the same as a prescription type. So again, try to look at the studies and try to see and make your own judgment.
with regards to your hyaluronic injection,
Yeah.
uh, is it, do you give them in early or late OA? Or is it
Well,
effective in late
yeah,
OA?
hyaluronic acid injections are usually, the studies are usually best in moderate arthritis. So if you give it in early arthritis, it's not cost effective. If you give it in severe osteoarthritis, they usually do not work as well. So the indication really is for moderate arthritis. Now you have a choice between the single shot or the one injection every week for 3 weeks. The single shot on the average it lasts for about 6 months. The one injection every 3 weeks, they say, depending on the brand, some would actually say the average would last about 11 months. So again, you decide what the patient wants in terms, again, budget issues, whether they're scared of needles, they want a single shot or 3 shots. But and whether the patient's already in so much pain at that time or not in pain too much. So I usually would give it when they're no longer in acute exacerbation.
One last question. I just had this question from one of my patients this morning.
Sure.
Uh, is there a role for PRP or stem cell treatment in OA?
Yeah. Actually, I was deciding whether I'm going to put slides on PRP. Personally, the way, well, what is PRP? So that's platelet-rich plasma. You get the lower part of the serum after you centrifuge the blood, and the PRP has a lot of substances we call cytokines, which attract the stem cells. They're not stem cells themselves, so they act like a magnet to stem cells. And your stem cells usually come from the blood. So if I give PRP to a osteoarthritic knee and there is no bleeding inside that knee, I don't see how the PRP can attract the stem cells. So we do use it in younger patients where we do arthroscopic treatment and microfractures where there is bone which is exposed and we put holes into the bone and now it now starts to bleed. So after that procedure, we inject the PRP and that is where I think that will uh, um, have, I mean, it would work. I mean, logically speaking. So that's in that instance, I would use PRP. But PRP again, the studies are still not very conclusive. Some say it would work better in patients who are relatively younger, less than 50, compared to those who are older than 50. Hyaluronic acid injection will work just as well if you're greater than 50. So, of hyaluronic acid, you don't need blood because basically it would work just on the cartilage.
Thank you, Dr. Dimayuga. Uh, if there are no other questions from our audience around the world, I would like to thank, yes, it's around the world. I would like to thank our two speakers, namely Drs. Dimayuga and Dr. Dunka, for a very enlightening webinar today. Good evening or good afternoon or good morning, wherever you are. Thank you.
Thank you.